we would like to share this experience of using real-time assessment of wash services in Venezuelan healthcare facilities. We would like first to explain a bit about the crisis and how things started. So from 2014 onwards, there has been a great economic crisis, the devaluation of the Bolivar, and this had a big repercussion on the wash services and health services as well throughout the country. One example is the lack of investment on healthcare facilities, which was set in 8% in 2006 and now falls into 1.5%, which is 75% below standards and one of the lowest in Latin America and Caribbean area. We also have to understand that we are dealing with a public health crisis. Venezuela right now has 400,000 cases of malaria, which is more than half of the total combined malaria cases of Brazil, Peru, and Colombia altogether. This has been very important because, well, Venezuela was the first country in the world to eradicate malaria. And obviously, well, water crisis, the wash services has been no exception. In 1998, 87% of the population had access to safe, clean water. And right now, 82%, which is about almost 29 million persons in Venezuela, has intermittent or no access to safe water, nor in quality or in quantity. So our response started back in 2019, so we are on year number 3. We started our remaining response approximately in May. The cluster was created also in this time. UNICEF also started activities and recruitment of staff around this period as well. In July 2019, the WASH cluster approach was activated by OCHA. And in October, we had funds to start interventions in 8 healthcare facilities, 4 of them in the capital, Caracas, and 4 of them in Zulia. And these were just punctual interventions, repair of pumps, repair of tanks, supply, provision of soap and some disinfectants. And this was proven not to be so sustainable. So next year, in March 2020, well, there was a COVID-19 outbreak throughout the world, and the response, obviously, so we decided to, okay, this is a great moment to start to think about a better approach and to think about sustainability of wash services. So we started to look on WashFit and its materials and manuals. We had them translated into Spanish and adapted to the Venezuelan context. At this moment, we already had implementation in 40 healthcare facilities, around 4 field offices that we established as well in the meantime. In March, UNICEF hired a WASH cluster coordinator for a full-time job. And we also established a WASH-specific and dedicated WASH IPC national working group with both health and WASH members. At the same time, we are creating the cluster. We also started to tell our partners and to give a lot of capacity building activities to our partners, such as explaining how the tool works and how is the WashFit methodology, and share with all the cluster members. And during June until December, UNICEF and its partners, and its 12 partners, conducted 204 surveys across 120 healthcare facilities throughout the country. 30 of them were main hospitals and 90 of them were primary healthcare facilities. This year, we decreased a bit of the healthcare facilities. We are right now in 74 healthcare facilities across 4 field offices and some satellite states. So we have expanded a bit further on our field offices. We've conducted up until the beginning of May a total of 96 surveys done by 7 partner NGOs and also UNICEF. We kept the number of hospitals, but we've decreased the number of primary healthcare facilities. Using WashFit was not easy in the beginning because there were some major obstacles to overcome. And specifically, I would like to highlight the knowledge of ODK or Kobo collection tools, even the understanding of the WashFit methodology and what is its approach and what is the benefits. Also some other issues such as security, access to healthcare facilities due to COVID, data collection, visualization mechanisms, and also even the existing IPC committees that were just purely medical stuff. And the WashFit methodology also proposes another methodology which includes other stuff, which is also proves to be a bit difficult. Nonetheless, the benefits outweigh the obstacles, and I think in 1.5 years of response in using WashFit, we were able to, first of all, prioritize interventions, and I think also the efficient allocation and use of funds was also a big advantage, especially allocating areas which we think are more important, such as healthcare waste, hand washing, environmental cleaning, and adjusting these interventions to each healthcare facility rather than having just a one-fits-all approach. Also enabled the WashFit methodology also enabled the creation and recommission of IPC committees, including a broader scope of people, such as patients, communities at large, maintenance staff, cleaners, which also allows these people to create constant feedback loops, both back to UNICEF, but also to partners and healthcare facility staff. And feedback loops then created also enabled better planning and to ensure all humanitarian actors and non-humanitarian actors also involved in and coordinated, also for budgeting and also for planning persons and hiring staff. And also, and this is a bit more difficult to measure, but also we've seen with our eyes that FIT was also a catalyst for staff and community motivation to improve WASH services overall. Just to highlight that this is one of the most key results that we use on WashFit. We've managed to have some substantial improvements across almost 1 year of interventions and analysis of WashFit. We've identified some key areas such as hand hygiene, management, water supply, cleaning and disinfection. And we've seen some great improvements up to 49%, overall 41%. We have identified the most common problematics, and those are highlighted here below in red, and the most persistent problematics as well. And this is very important to understand the sustainability of our services in the future. Well, thanks to WashFit assessments, first of all, the staff capacity was developed and increased, and this is very important. And staff, not only for healthcare facility staff, but also UNICEF and its partners. The prioritization of need, as told before, also allowed to produce higher impact, considering as we said before, in the environment of scarce resources and everything is very expensive. And salaries, and it's very important to prioritize where we're going to intervene and which actions have more impact, especially when you're considering on where to deal, and especially for the activities to engage motivation. And especially because we've seen in a country that has a lot of brain drain and immigration of people, and it also allows us to identify some solutions to improve WASH services, and some of these solutions are quite integrated, and I would like to highlight one of them, which is the installation of electrolytic chlorinators. In coordination with the Minister of Health, we've decided these solutions were one of the most practical solutions and the most cost-efficient solutions. Also because it contributes to 3 outcomes at the same time, so water access, disinfection of water, sanitation, that's even though it's not sanitation, but also make sure that these sanitation facilities are kept in the most hygienic conditions, and also hand hygiene and cleaning and disinfection, obviously. The immediate impact of this is, first of all, an improved infection prevention and control, and also allows us to use the resources for other things, and also reduces the healthcare costs, not to the patient because we're dealing with a socialist country, but anyways, it reduces healthcare costs also to to the service provider, to the Minister of Health. And also, and this is a bit more indirect, also improve staff morale and performance, because when they see that the spaces are cleaner and more and safer, and of course people would like to make sure that these places are used, and also for patients also feel that they can use these services a bit more. Also, I'd like to highlight that this also has long-term impacts. I think at the long run, we will see a bit increase of dignity in child mother care services to better wash services provision. And also we're going to see lower mortality and infection rates, even though Venezuela does not have right official numbers on this. We can see that this is going to be one of the long-term impacts. Of course, and one of the other impacts I'd like to see is that also contributes to the more productive families and communities when they use these services. And involvement of the community has been very fruitful, and this is something we'd like to share with you. So, first of all, in the UNICEF response, the installation of these saline electrolytic chlorinators were installed in 35 main hospitals across the country. This equipment allows the production of about 4 liters of chlorine per 1 kilogram of table salt. And this could be used for disinfection of, producing water for disinfection of hands, but also producing of disinfection for cleaning surfaces and disinfection of water. So this one single equipment can have all these benefits. Since the beginning of this project, we have involved the communities, the surrounding communities, to understand their needs and for this commodity they're going to produce as well. And thanks to the support of maintenance staff and their initiative, and also the community leaders, we managed to establish some kind of exchange mechanism. So basically, communities could, in some hospitals that we've done this, is that we've seen that if the community provides salt back to the hospital to produce chlorine, then this can be exchanged with other commodities. So if the community provides salt for the chlorinators, then they receive the chlorine and they can use the chlorine or the salt to exchange for other things that the hospital can have, and they can use it for their homes. We've seen in some states that this is very useful for exchanging salt with hand sanitizer and soap and other commodities that create this win-win situation. For the hospital, well, the need of supplies, it's lower. And also for the hospital itself, well, there's less patients, then they can have more control of their patients, they have better care, but also reduces infections and the cost of health services, obviously, in the long run. Well, for the next steps, I think, and we would like to work a bit further with expanding this tool to other clusters, especially nutrition, especially because we are still with a protracted crisis and COVID-19 is still here, but we cannot forget that this can also apply to other infections related to nutrition. So we'd like to have this promotion of this tool to partners to use them, and but also to inform them to our donors. We would like to improve analytics. We understand that data visualization is a priority, so the use of Kobo and link to Power BI and other tools that allow us to ensure that everybody understands and visualizes the information at real time, it's very important. And publishing on the WASH cluster websites, but also the learning and the knowledge management. We would like to focus really on the common and the persistent problematics and keep revisiting them so we can generate these approaches that have impact and identify the healthcare facilities that we manage to produce good results. We would like to keep working on AAP mechanisms to keep gathering information about what are the needs of the communities and what are the needs of the staff, and how can we also incorporate these responses and keep working with all these people and to improve our response. And also promote the use of WASH-fit methodologies to improve their own methodology for the Minister of Health. This also allows us to make sure the protocols and some legislation are adapted, perhaps, and make sure that they are streamlined with the most up-to-date standards.